So, good morning to all. Today's topic is chest injuries, and we have been discussing about the basic management of trauma victims over the last 3 hours. And now we are going to one most important areas of trauma, that is management of chest injuries in trauma. If you ask me what is the significance of this has got a lot of significance because as you all know that 25% of traumatic deaths are due to chest injuries, and the most important thing is almost 75% of them are preventable deaths. So a basic knowledge about chest injuries are mandatory for us to plan the treatment as well as to outline the pathophysiologies. Right. So it is an important topic to know on a practical terms, and when you look at the different papers, both for the postgraduates, undergraduates, and the pre-PG students, you find that a lot of questions come from this area also, both in terms of essay questions, short questions, as well as MCQ questions. So, you need to know about the basic concepts in the management of chest injuries and how will you approach the problem. Right, like we already said before, basic management of all trauma victim is emergency resuscitation. There is no change in it. But when it comes to zone into the region-wise injuries, you need to know a little more depth into each area so that you don't lose the focus of attention to those specific problems. So, chest injuries, as per se, accounts for around 25% of post-traumatic deaths, and this is one of the most common cause of deaths due to trauma. We will think it is a head injury, but basically chest injuries comes as the first priority. And not like that, not only that, they also account for, as I started with the statement, that they are also preventable causes of deaths. And as you all know, the basic cause of death in chest trauma is due to hypoxia, hypercarbia, and hypotension. So you need to be very wary about these things when you manage the three H's of trauma: hypoxia, hypercarbia, and hypotension. My address to the whole problem will be taking care of all these things and then take it systematically by the different region or the zone wise. So, for anatomical description of trauma of the chest is divided into three zones for a description purpose. Basically, the management remains exactly the same. But for a description purpose, the post-traumatic injuries are divided of the chest is divided into three zones. Zone 1 means it is the chest wall, that is the ribs and the pleura. Zone 2 is the lung parenchymal injuries, and zone 3 is the mediastinal injuries. And as you all know, all the three zones are vital, and they also give a direction, or they also give a clue that what is the nature of injury in the other zones also, if depending upon the severity of injury. So we need to know the zone wise, but the most important thing is you need to know the zones because it is easy to describe each zonal injuries by one. So what are the common zone wise injuries? We'll go to that by one. Once again, zone 1 is chest wall and pleural cavity. Zone 2 is the lung parenchyma, and zone 3 is the mediastinal injury. Now, when we go to the zone 1 injury, what is the most common injury? The most common zone wise in zone 1 injury is the rib fractures, the fractures of the ribs. I'm sure that most of us are familiar with it. But when you're having fractures of the ribs, we need to know the basic things about fractures of the rib. The one and the foremost is, you know that there are 12 pairs of ribs on either side attached to the sternum, isn't it? And these ribs are having peculiar characters of the different parts of the body or different zones, again on the rib cage. You know that the first three ribs are pivotal in that they are the most protected ribs, right? To fracture them, the body has to undergo very high velocity trauma. The ribs from 4 to 9 are the ribs which are exposed ribs and which get fractured very easily, right? And the ribs 10, 11 and 12 has got a significance that whenever they are fractured, there is a high risk of intra-abdominal injuries. That is on the spleen on the left side and the liver on the right side. So you need to be having an idea regarding what are the differences in the basic fractures. Now, when you take about the ribs fractures one by one, the commonest rib site of the rib fracture is the angle of the ribs. The angle of the ribs is the most vulnerable fracture or the region of the ribs where it can bundle up and fracture, right? So, angle of the ribs is the most common site of fracture ribs. That is the most important thing. And when you look at the angle of the ribs, and they can be a simple rib fracture, that means that is not communicating to the pleural cavity or not associated with any pneumothorax or hemothorax. But rib fractures can be complicated also. Rib fractures can be complicated by in the form of either in the form of a pneumothorax or a hemopneumothorax, and they can induce lung parenchymal injuries also. So the position of the ribs are very important, and depending upon the number of the ribs or the nature of the ribs, there can be a problem related to the pleural cavity or related to the intra-abdominal region. I want to take the rib fractures as a whole. What are the common symptoms? The most common symptom with the rib fracture is an intense pain because of the movement of the rib cage. Second thing is if it injures the pleura, you will get a surgical crepitus as well as you can get surgical emphysema. And if it is communicating to the pleura or when the pleura is injured, you can either produce hemothorax or pneumothorax. That is the most common presentation. We call it as a complicated rib. So, uncomplicated ribs and complicated rib fractures. Now, I want to address the fractures of the first rib as a separate entity. Fractures of the first rib is peculiar in that, they are hidden ribs. They are hidden ribs in the pleural cavity, isn't it? They are protected by the thick muscles of the neck as well as the clavicle. To fracture them, it requires a very high velocity. And when the first ribs are fractured, there is around 30% chance of intra-abdominal injuries and intrathoracic injuries. And they also carry a very high risk of injuries to the lung parenchyma and the lung lacerations and the mediastinal injuries. So they are the ones which carries a mortality. Again, we can put it to 25 to 30%. So whenever you find a first rib fracture, isolated first rib fractures, always be beware of a vascular injury, thoracic injury and intra-abdominal injury and try to rule it out. The management remains exactly the same. Now, how will you manage a simple rib fracture? When you have got a simple rib fracture, then the management is very simple. All you need to take care is the pain, right? You need to relieve the patient with the pain so that the oxygenation, the chest wall movement becomes okay and the patient respires well and the oxygenation becomes normal. But when there is a fracture rib, with a complicated fracture rib with a hemothorax or pneumothorax, your first priority should be to drain the pneumothorax or the hemothorax, right? Because otherwise it will lead on to a consequent hypoxemia, right? Even with a simple fracture, you will have a hypoxemia because the patient is not respiring. But if it is a complicated rib fracture, the primary reason for the hypoxemia is because there is a collection of the air on the pleural cavity or the blood in the pleural cavity. So you need to drain it. Now, so what are the systematic management? Taking care of the airway breathing and circulation. Give analgesia to relieve the pain. Give oxygen by mask and cetal saturation. If there is pneumothorax or hemothorax, you drain it. That is a protocol. Now, what the last point is, what is the best analgesia for a rib fracture? The best analgesia for a rib fracture is intercostal blockade, because all analgesics will work at a higher level, but intercostal blockade will work at the site by giving the block. Where will you give the block? Intercostal blockade is given by using lignocaine or bupivacaine at the lower border of the upper ribs at the angle of the ribs. Right? You can give the block either onto the two ribs above and two ribs below and onto the site of the rib so that the entire field is blocked and the patient will be relieved of the pain. So the best analgesia for in rib fractures are intercostal blockade. So that finishes simple rib fractures. Now coming to the next topic, that is a flail chest. What is flail chest? Flail chest is a complicated rib fractures. What is flail chest? What is the definition of flail chest? Flail chest is nothing but when two or more ribs are fractured at two different positions, either on the same side of the diaphragm or on either side of the same side of the sternum or on either side of the sternum, you call it as a flail chest. And when it occurs on either, when the same through or more ribs are fractured on either side of the sternum, what will happen? The sternum will appear as a free fragment. So what is the problem with that? The problem with that is that this will manifest as a loose fragment, and that is called as stow and chest, right? And when it is a lateral flail, it is called as a lateral flail chest. Now, what is the pathophysiology of flail chest? What is the problem with the flail chest? The problem with the flail chest is the segment which is fractured will act as an isolated fragment. So what happens? If the patient breathes, what happens normally? The lung expands, isn't it? And the chest wall comes out. But here, this fragment is a fragment which is loose. So what happens when the patient inspires? This fragment will go in, right? So what will it cause? It will cause the reduction of space for the lung to expand. So what will happen? Then that will lead on to an added hypoxemia. And that is called as the paradoxical respiration. And paradoxical respiration per se will be present both in conscious and unconscious patient. There is an entrance question asking, what are the factors? All the following statement about the flail chest are wrong or right, except, and the answer was paradoxical respiration will be present whether the patient is awake or whether the patient is the unconscious, because it's basically a symptom, basically a manifestation of the lung movements, right? Now, that is the first pathophysiology, that will reduction of the that will cause hypoxia. Then what is the next problem? When there is an added pneumothorax or hemothorax, what that will cause? An added hypoxia, right? So basically, flail chest lead on to paradoxical respiration, hypoxia, hypercarbia, and later on to hypotension because of the reduction of the venous return. Now, how will you manage? What is the basic investigation? The best investigation to demonstrate all these things are an X-ray chest, also a CT chest, which will tell you exactly all these factors of fracture ribs, pneumothorax, hemothorax, and what is the grade of the depression of the fractures. That is what is picked up by a CT. And you should always do an ABG because that will tell you whether the patient is in respiratory acidosis. So, how will you manage this patient? Management of the flail chest per se is basically managed by, if there is an asymptomatic or a patient with a reasonable saturation, the patient is always managed in an intensive care unit. Flail chest ideally should be managed in a monitoring situation. You can't put them in the ward and be happy. You should monitor on a dynamic basis about the hypoxia. So always look at the patient and look at whether the patient leads on to hypoxia. So initial management is airway, breathing, circulation. That is always there, D and E. Then what will you do? You give analgesics. You can give intercostal block and give oxygen by mask or high flow nasal oxygen. That will take care of the saturation. Then what next? If the patient has got pneumothorax or hemothorax, the next option is to go for a ICD or ICD for intercostal tube drainage, for drainage of the hemothorax or the pneumothorax. Then if the patient is not subsiding, then give analgesia so that again the hypoxic, the pain is relieved so that the hypoxia is taken care of. And if still the patient is hypoxic and oxygen saturation is not coming up above 90, it is a time where you have to think about intermittent positive pressure ventilation, and that is the treatment of choice for a flail chest. So you go in a graded fashion, in a systematic approach. But if somebody asks you what is the treatment of choice for a flail chest with hypoxia, it is intermittent positive pressure ventilation. Now, what about operative fixation? Operative fixations are advisable when there are the overriding of the fracture segments for more than 3 centimeters according to textbook of surgery by Bailey. And what you do? You do an operative fixation by using plates. The ribs are plated on and then fixed around. And that is the treatment of flail chest, and the patient has to be monitored, and most of the patient comes and should be given adequate pulmonary exercises so that the lung expands. And once the lung expands and the saturation level becomes normal, if you are put in a chest tube, you can take it out, and also you can manage and give intercostal block analgesia so that the patient's pain is relieved for a long term and patient won't go hypoxia. So the management is very clear. That is, we already summarized the management as flail chest of the management of the flail chest as analgesia, intercostal blockade, drainage by ICD if there is pneumothorax. If there is still hypoxia, give intermittent positive pressure ventilation, and operative fixation is very less done, less than 5% of the cases. But when there is an excessive reduction, as a theoretical point of view, you can do an operative fixation. So that finishes the chest wall injuries. I am talking about blunt injuries of the chest. Now coming to the next thing, the pleural and the pleural injuries, which is either a pneumothorax or a hemopneumothorax. In traumatic scenario, most of the time they are pneumo or hemopneumothorax. But the most worrisome thing is when there is a significant hypoxia due to this, because the most important thing is tension pneumothorax is the most common entity which can be cured by a single point action. So you need to be very wary about this, and you should be understanding exactly what to do and a stepwise approach, and it is a clinical diagnosis and a rapid clinical intervention in a tension pneumothorax. So, but just for a completion's sake, let's see what are the types of pneumothorax. I'm talking pneumothorax in general. Pneumothorax can be a closed pneumothorax where there is a leakage and it is contained inside the pleural cavity. It normally occurs when the rupture of a bulla or sometimes when there is a single fracture ribs. Second thing is an open pneumothorax when there is a wound on the chest wall, especially a penetrating or an impalement injury, and air comes and goes out. That is called as the open pneumothorax. And the third one is a one which is called as a tension pneumothorax, where there is a continuous leak of air from the lung parenchyma and it is contained in the chest wall, and that will lead on to a continuous compression of the lung, and that the lung will be completely collapsed. And once the lung is collapsed, what will happen? It will reduce oxygenation, and as it continues, it will lead on to hypotension because the venous return gets impeded and the patient will go for an irreversible shock. So, pneumothorax, you can see on the picture on the left side, that is the pathophysiology that happens, and you can see on the right side, right side picture, where X-ray shows a hyperlucent shadow. Now, how will you diagnose pneumothorax? Pneumothorax is diagnosed purely on clinical basis. You suspect, you auscultate, and then find out there is a reduction of air entry in a post-traumatic patient on one side. Unless the patient is aspirated, it is a pneumothorax and you need to act immediately. You look at then what will you do? You look at the SpO2 and see whether the SpO2 is reduced. The pulse rate will be increased. Patient will be complaining of pain. There can be hypotension, right? And in some cases, when there is a massive injury to the chest wall, you can get the surgical emphysema, which is usually confined to the chest wall, or it can extend to the neck, and in severe cases, it can extend to the whole of the upper abdomen and sometimes to the lower abdomen also. I have seen cases like that, right? But what is the investigation of choice? Investigation of choice for a pneumothorax is plain X-ray. An X-ray chest is the investigation of choice, which can definitely diagnose the pneumothorax as well as a collapse. You can see it's a hyperlucent area on the right side, and you can see the collapsed lung shadow close to the mediastinum, and will be a shift of the trachea to the opposite side, the mediastinum to the opposite side, right? So X-ray chest is the best investigation. But what is the most accurate investigation? The most accurate investigation to detect a minimal pneumothorax is the non-contrast CT, which can even detect it up to 1 ml. That's the most sensitive investigation of the air. And contrast CT has got an advantage because it can tell you the depth, the extent, and the extent of the different types of injury. So whenever you have got a complex injuries to the chest, CECT is the best investigation in a blunt trauma chest. X-rays definitely will give an information, just like in this case where either you can see that there is a massive pneumothorax and the mediastinum gets shifted also onto the other side. So now what will you do? Again, management start with strict observation, emergency resuscitation in the terms of airway, breathing and circulation. Then what will you do? As an emergency treatment, the first option is what is called as a needle thoracostomy. Needle thoracostomy previously was described in the second intercostal space in adults and children. But now, according to the new guidelines, the needle thoracostomy, that is using a number 14 gauge needle, you put it inside the chest wall, straight at the mid-clavicular line. That is what the initial thing, initially that was a concept previously in adults, and connected to an underwater seal. But now, needle thoracostomy for adults is done in the fifth intercostal space in the mid-axillary line, and for children, it is done in the second intercostal space in the mid-clavicular line. And what will you do? You put a needle in that space and connect the end of the needle. You can connect the end of the needle to an underwater seal. Right? That is an emergency procedure. It is not a definitive procedure for tension pneumothorax. Now, what is a definitive procedure for tension pneumothorax? The definitive procedure for tension pneumothorax is a tube thoracostomy. Tube thoracostomy itself acts as a short note. Now, when you're asked about a short note on tube thoracostomy, what will you say? Tube thoracostomy, you have to say the indication. What are the indications? Any case of whenever there is a collection of the fluid or air in the pleural cavity, which can be a pneumothorax, a tension pneumothorax, an open pneumothorax, a hemothorax, hydropneumothorax, or whenever there is a malignant pleural effusion sometimes, isn't it? Or when the patient has got empyhemathoracis, you have to put it inside the thorax. So those are the indication for tube thoracostomy. Now, what is the position of the patient? That position of the patient is supine with the arms abducted. Then what will you do? Then what will you do is you will drape the area. And you should know where exactly you are going to put the chest tube. Chest tube is always put in the triangle of safety. What is triangle of safety? Triangle of safety is bounded by the anterior axillary fold, the mid axillary line and the fifth rib. And you put in the tube in that area because that is the area which has got a least chance of injury to the abdominal structures and diaphragm. Right? That is, it is above the diaphragm and liver on the right side. It is above the diaphragm and the spleen and the stomach on the left side. That is why that is called as a safety triangle. Right? And you always make an incision at the upper border of the lower rib. You put a artery forceps, dilate, and then once you reach the pleural cavity, you put a finger and separate the pleural adhesions and put the tube in. And once you put the tube in, you connect it to an underwater seal. Why are you connecting to an underwater seal? You want to know whether you are in the pleural cavity and whatever air is there that is leaked into underwater so that it won't go back. Right? If you're keeping it outside, what will happen? It will go back and there will be a continuous, converting a tension pneumothorax into an open pneumothorax. And now the question is, how will you know the tube is functioning? You will know the tube is functioning by the oscillating column. Right? The next question is, when will you remove the chest tube? You will remove the chest tube only when the drainage becomes less or the patient's lungs are clinically and radiologically expanded. That is the best answer. But there was an entrance question in AIIMS which asked about when will you remove based on the amount of the drainage. The amount of the drainage less than 50 ml on 3 consecutive days in a patient with a hemothorax can be an indication to removal of the tube if the lung is expanded. So, less than 50 ml on 3 consecutive days, you can remove the tube. So that is how you manage a tension pneumothorax. Last but not the least, how will you remove the tube? Once the lung is expanded, what will you do is you go there, you go to the patient's side, you cut down the sutures which you have placed, on holding the tube, take a gauze piece in your hand, ask the patient to deep breath so the lung is expanded. You pull out the tube and seal the wound. Right? That is the way in which you remove the tube. Now coming to the next entity, the open pneumothorax. Open pneumothorax is caused by a sucking chest wound, something like an impalement injury. Right? and the air comes and goes out. So what will happen? There is a large defect in the chest wall, and that is causing the sucking of the air, and that will lead on to progressive collapse of the lung. So what will you do? The first thing to do is, or the initial treatment is what is called as a three-way occlusive dressing. It provides a flutter valve effect, and that will prevent an entry of air inside the pleural cavity, but allow the air to come out. This is the three-way dressing, where you keep the dressing on the three sides. You keep the dressing on the three sides, and then you can ask the patient to be transported to a higher center. So what will happen when you keep a patient on a three-way dressing? Whatever air is the patient is inspiring, no air from outside will go in. But when the patient is exhaling, what will happen? Or when the lung is expanded, whatever air collected in the pleural cavity will go out. So that will reduce the possibility of a tension pneumothorax or exaggeration of a normal pneumothorax. Is it the final treatment? No. What is the final treatment for a sucking wound or a open pneumothorax? You need to close this wound, isn't it? So you take the patient to theatre under general anesthesia, debride and close with an intercostal tube drainage. So the final treatment or the final treatment of choice for a open pneumothorax is you are closing the chest wall wound along with an intercostal tube drainage. That is the final treatment. Okay, so that is a treatment of an open pneumothorax. Now, what is the treatment of a spontaneous closed pneumothorax? Spontaneous closed pneumothorax in the present scenario can be managed as an observation. You don't have to put in a chest tube all the time. So, it is a minimal pneumothorax, spontaneous, patient is hemodynamically stable, there is no hemothorax or gross hemothorax or pneumothorax, saturation is well maintained. These patients can be observed and can be managed without a chest tube. But if it is a massive pneumothorax, even if it's closed, it has to be drained. Massive pneumothorax, there is no doubt it has to be drained immediately by a needle thoracostomy as a permanent measure by an intercostal tube drainage. And take it from me, all the surgeons, all the emergency management people should know how to put a chest tube. Now, hemothorax also, the management is exactly the same. You put in a chest tube and monitor the drainage. So you put in a chest tube and you have seen that the drainage is not coming down or drainage is increasing. You are worried whether the patient has got an intrathoracic injury. What is your next option? Next option is to do an emergency thoracotomy. That means you have to open and see, isn't it? Because there may be some hidden causes of the injuries to the chest. So how will you decide which patient goes for a thoracotomy after you put in a thoracic tube, intercostal tube? It is based on certain objective or dynamic findings. What are the dynamic findings indicating an emergency thoracotomy? I will say one thing. The most important thing is hemodynamic instability in a patient with a trauma to the chest and you are put in a chest tube. You find that there is a drainage which is increasing and the patient becomes hemodynamically stable. No values are cut off. You have to take the patient. So the first and the foremost is hemodynamic instability. The second statement I said was when there is a increased ongoing drainage or blood loss. But there should be some figures. What are the figures? Then it is said that when there is a massive hemothorax, that when you put in a chest tube and it drains more than 1500 ml on an initial insertion or 200 to 300 ml per hour after initial drainage. That is, every hour you get 300 ml drainage. That means there is a continuous bleeding and you need to go and say, have a look. Right? So, or 100 ml within 15 minutes or 15 minutes for 1 hour, that is also an indication for an emergency intervention. So, 1500 ml on initial insertion, 200 to 300 ml per hour, or when you have got immediately within putting in a tube 100 ml per 15 minutes in the next 15 minute interval, that is an indication to have a quick look what is the problem. What are the other indications? Other indication is to when you have to give an emergency internal cardiac massage. Very rarely done. That is one. I'll leave that to outside. Then what is the third one? Penetrating injuries to the chest and the pleura, and especially when it is in the danger zone, when it is in the danger zone of between the nipple lines on either side or the midclavicular lines on either side, then there is a chance of the mediastinal injury you need to explore. The fourth is tracheobronchial injuries. All tracheobronchial injuries, unless proved otherwise, you need to explore. Esophageal injuries, you need to explore. Major thoracic vascular injury like an aortic transection, you need to explore. And when there is a diaphragmatic perforation, you need to explore and close it. And another thing is retained foreign bodies. Whenever you find a retained foreign bodies like a bullet, like a piece of a knife, which is retained inside the pleural cavity, it is always better to do a thoracotomy. So once again summarizing, the most important thing for an emergency thoracotomy in a trauma scenario is whenever there is a hemodynamic instability, continued blood loss immediately with as soon as you put in the tube more than 1500 ml, or 200 to 300 ml in the next hour, or more than 100 ml per minute, 15 minutes, you need to interfere. Tracheobronchial injuries, esophageal injuries, the major vascular injuries, diaphragmatic injuries, and retained foreign bodies. Last but not the least, I said was the injuries to give internal cardiac massage. So that is but very rarely done. Sometimes you may have to do an internal to do that by you have to give an internal cardiac massage. You open the thorax in the emergency room, and to give especially when there is a cardiac tamponade and cardiac arrest, you have to stimulate the heart because that may be life-saving, and then take the patient to theatre. So these are the indications for emergency thoracotomy in a polytrauma patient. So the topic I discussed today in the early morning was the classification of chest injury, the zone-wise chest injury, the rib fractures. First rib fracture itself is a short note, the flail chest, then comes the pneumothorax, tension pneumothorax management, intercostal tube drainage, that is a short note, and also the management of the open pneumothorax, as well. That is an MCQ question. Then indication for thoracotomy after you put in a chest tube. I also said practical point, when will you put in, how to put in, how will you remove the chest tube. These are also asked as short notes. What are the complications of intercostal tube? That is the last thing which I want to discuss in this class. The complication of chest tube is, one is all injuries to the pleura, injuries to the intercostal vessels, injury to the lung, injury to the vascular structure if you push in the tube hard. Second is infection, because if you keep it for a long time, it can lead on to empyemothoracis. Third is when you have got, when one of the holes slips out, it can cause significant surgical emphysema. So with that, I am stopping the first session on chest injuries. That is a very important zone 1 injuries and classification of chest injuries.